There is a brand new initiative in Ontario for people and their caregivers who are living with dementia. The Alzheimer's Society of Ontario and the Brainwell Institute have partnered to create the Ontario Dementia Task Force, and we are learning all about it today with Dr. Saskia Sivananthan. Welcome to the Heart of It All, sponsored by RBC Wealth Management. We are a podcast all about caregiving, and I am your host, Teri Hart. We know that caring for a person living with dementia can be one of the most challenging forms of caregiving. This is a disease that can be long and drawn out, and making decisions is incredibly difficult for caregivers. With Canadians living longer, navigating the transitions of aging requires more than financial foresight. It takes vision, purpose, and a plan to write the chapters that will define each stage of your life. RBC Wealth Management is helping clients navigate the longer run with confidence, resilience, and purpose by integrating financial expertise with a deeper understanding of aging, health, and family dynamics. They've partnered with experts in caregiving and wellness, including brain health, because the earlier you have these conversations, the better. Having the right people in place at the right time matters for both your wealth and your health. At the beginning of June, a very exciting announcement came out from the Brainwell Institute and the Alzheimer's Society of Ontario about a new task force for dementia care. Here to walk us through the plans and what we can expect, CEO of the Brainwell Institute, Dr. Saskia Sivananthan. Welcome so much to the Heart of It All.
Thanks for having me.
So let's start with the Brainwell Institute. What is it and why did you create it?
So the Brainwell Institute actually was created out of frustration. My co-founder, Alexander Waite, and I had worked together for several years. We've both been in the dementia space. We both had lived experience of dementia, of caregiving, working with people living with dementia. And one of the things we noticed was over and over again, what kept coming up is system fragmentation. People just didn't know where to go. They would fall through the cracks. They would wait years to get a clear diagnosis. And that's just to get the diagnosis. And then once they get it, there was just no, what do you do next? Like, you're on your own. Good luck. And we had been at many policy tables and round tables talking about the need for coordination, a pathway through the health system, etc. But there was this big just chasm between that conversation and it actually happening. And so we established the Brainwell Institute specifically to achieve that goal. It's a nonprofit organization. It's a think tank. And it is focused entirely on dementia and brain health because there's a whole aspect to risk reduction that we can dive into. But we really wanted to take the evidence, build the evidence, and move that into policy. So it's not just about the thinking, it is also about the doing. And we have a 7-year mandate. And the goal that we want to achieve is to put ourselves out of business. We want the Brainwell Institute to be redundant after those 7 years. Because if we've done our job right, we've been able to bring all of the players, all of the people living with dementia together to have achieved this coordination of care to help set that vision and that path. And then we've achieved what we needed to do and we can wind down.
I can hear people in cars on their walks, cleaning their houses, yelling hallelujah when they hear that. Because boy, oh boy, do we need this. Can you give folks an idea of the numbers in Ontario and broadly speaking in Canada of folks or families who are living with dementia?
Yeah, okay. This is a great place to start. I'll start with the Ontario numbers. As one of the bigger provinces in Canada, we're looking at about 300 to going up to 400,000 Canadians who will be living with dementia in Ontario. When we're looking at the Canadian numbers, we're projecting about 1 million Canadians who will be living with dementia in just 4 years. Now, those are the numbers of people who will be living with dementia, but we know that for every person living with dementia, there is at least one caregiver, if not many, many other caregivers. So we're talking at least 2 million people, right, who are living with dementia. But here's the thing that often goes unnoticed, and I think it's worth us talking about. the rate of dementia in Canada are declining. So how can both of those things be true? And I want to give you a little bit of an analogy to see if this can help explain it. We're looking at numbers and then we're looking at a population, right? And so we have done a really good job of starting to reduce the individual risk of developing dementia. But the numbers of people who will be living are increasing because Canadians are getting older and living longer. So here's an example. Cars today are safer, generally, because we have mandatory seatbelt use, right? Protective car seats, airbags for passengers. So all of that means is that the risk of dying or being seriously hurt in a crash have decreased for every kilometer you're driving. But we now have more cars on the roads. We have more people who are driving further than they ever have before. So the total number of traffic fatalities are still or could still be increasing. So it's the same idea with dementia. Our individual risks have decreased, probably because we've done a lot to understand heart health, and reducing the risk of heart health is linked to your risk of brain health as well. But the number of Canadians who are aging is increasing. And our Canadian population is older and we're living longer, which means that the numbers are also increasing. So it feels like this weird contradiction, but it is the case. Our numbers are projected to reach 1 million, even though our rates are falling.
Yeah. And you said something there that interested me, that heart health and our improvement in people managing their heart health has a direct correlation to those being diagnosed. I don't think I ever realized that heart health and brain health or a dementia diagnosis was that clearly connected.
Yes, they are through their risk factors. So there's a huge study called the Lancet Commission that happens every couple of years. And what they did was they started trying to understand at a population level, what are the risk factors that contribute to developing dementia? And they found 14 risk factors, and those risk factors are increasing. But many of those risk factors are the same risk factors linked to heart health. So exercise, physical activity is one of the highest risk factors linked to developing dementia as well as linked to vascular disease. The other is diet, right? The same factor that is linked to heart health in terms of a healthy diet is one of the key factors linked to brain health. So this is how it goes. There are about 5 to 6 common risk factors. And because we did start many years ago trying to increase the population's awareness around those risk factors for heart health and have started to impact and reduce the risk of vascular disease or heart health, they're linked to, therefore, why we're starting to probably see the decrease in rates of dementia as well. But there are risk factors that are specific to dementia that have nothing to do with heart health. And that's also why, they're not exactly correlated.
So habit stacking is important for all kinds of our health. And I am going to remind people, because it's my favorite thing to remind people, get your hearing checked, folks. It is the number one modifiable risk factor for dementia, hearing loss. Dr. Sivananthan, what do you think people misunderstand about dementia or don't understand?
After so many years, it's been almost 2 decades that I've been working in this space. And I still hear a bit of this coming up. And there's 2 pieces. The first is people still think of dementia as a condition that they can't do very much about. And that is a normal part of aging. And look, yes, as we get older, there's going to be some memory loss. Just like all parts of our body are slowing down, our brain also is going to have some of that, slower processing when it comes to cognition. But dementia is a condition and it's a collection of diseases. It's over 100 different diseases that fall under this umbrella of dementia, and people misunderstand that. They first think it's not a disease, and then they think it's one disease, when actually it is a collection of many different diseases. So the analogy I use often is when we talk about cancer, it's an umbrella term, And I think we understand now that there are many different types of cancers, right? From lung cancer to prostate to, pancreatic, and they have different trajectories. They also have different symptoms that can manifest. Dementia is the same. It is a condition. Alzheimer's disease is the most common, and that is where forgetfulness, that cognitive decline, is one of the first symptoms or flags. But there are so many other types of dementias. They can impact you at different ages. Frontal temporal dementia is one, for example, that impact people in their 50s, 40s, or 50s. And the first signs are actually not forgetfulness. The first signs can be language loss or personality changes. Then there's vascular dementia. There's Parkinson's-related dementia. And I think that is such a big misunderstanding about this condition. And then the second piece is the stigma around it. People look at dementia and they think there's nothing we can do about it. There's no ways to treat it. We can't reverse it. And so let's just put it off and not deal with it until we absolutely have to deal with it, which is often in crisis. And that is not true. There are many things that you can do and put in place to live as well as possible with dementia. And I don't want this to be taken the wrong way, in that the trajectory of most forms of dementia do end with the person being unable to care for themselves. This is true. And you can die of dementia. It is a fatal condition. But this is a long, long disease, right? We're talking 8 to 10 years, depending on the type of dementia you have. That's a long time to live with it and think that there is absolutely nothing you can do about it. There are many pieces, right, that you can put in place along that trajectory to live well, to live purposefully, and to fulfill the things that you want to be able to do. And the same goes for caregivers and care partners. So I think that's the second piece that is misunderstood about this disease and this condition overall that I would love to dispel.
Well, yes. I mean, I'll tell you, my dad had vascular dementia brought on by a couple of strokes. And when I first heard vascular dementia, when we went to a neurologist, and I was like, no, he doesn't have dementia. And they're like, no, vascular dementia is a form. And I had to immediately educate myself. I had no idea. And for the record, my mom is a retired nurse. She understood it. But, you would think that I would have had some understanding. People just don't understand the different kinds of dementia, how they present themselves, and what the possibilities are. So knowing all of that, you recently, I said in the intro, a really exciting announcement came out at the beginning of June about the Ontario Dementia Task Force. What is it, and why have you established it?
So the Ontario Dementia Task Force is, well, first of all, it's hosted by the Alzheimer's Society of Ontario, and it's funded by the Weston Family Foundation. And what it does is it brings together all the major organizations across Ontario that deliver any form of care to people living with dementia and to their care partners. So I mean this both from the clinical perspective or the medical perspective as well as the social, because this is the thing about dementia, right? It is it's a promiscuous disease in a sense. It's not only a health or medical condition. It impacts your ability to drive. It impacts housing. It impacts how you're going to be interacting in your community, finances, so many things. And what we wanted to do was acknowledge that broad scope, but also the fact that, again, what we kept hearing from people living with dementia and their care partners is they have to navigate this system and they have no idea where to go, how to start. They'll often be told that there are 12 different places you need to call, and each of those 12 different organizations will have their own intake process. So you're telling your story over and over and over again, and it's disconnected. And basically, the caregivers and the families become like air traffic controllers, right? Trying to figure out which route to take and how to take it. And this is because we believe the root cause is a lack of coordination at the provincial level. We don't have eyes on all the different ways in which people living with dementia need to navigate what that path through the system is. We don't have a path for dementia the way we do have a path for other major conditions like stroke, cancer, palliative care. And so we need to establish that pathway through the health system for dementia. And we need to start having accountabilities around what would those outcomes be that are positive that we want to establish within the health system, and how does that integrate with the social system. So the organizations around the table represent all of those different sectors, from acute care, home care, community care, Alzheimer's disease, Parkinson's, Huntington's, people living with dementia, medical associations, who have agreed that, yes, we need this coordination and we're willing to help build that roadmap in Ontario.
We use the word the system so frequently. Can you break it down? What is the system?
Yeah. Yes. Okay, I'll take a step back. There are a couple of systems, actually. You're right to ask the question. There is the home care system. We could start there, for example. Often, when a person has gotten a diagnosis, they're told, okay, you need to connect with home and community care. But that's not one system. That's actually many systems. There is a place where you can access home care, where it's a personal support worker or a social worker who can come to your home, who can assess the kind of supports you might need for day-to-day care. So things like, do you need support with bathing, with your personal care needs, with, getting a meal? Then there's Meals on Wheels, which is a part of a separate community support system in place. Then there's the Alzheimer's Society, which is a nonprofit organization that offers those kinds of supports that are free. And it might be, here are other people, here's other caregivers who are dealing with the same condition. Here's a support group that you can access. If you're a person living with dementia, here's a different support group you can access. There's a program called the First Link program that the Alzheimer's Society offers that helps you figure out how to navigate the system. Those are a couple of systems. Then there's the clinical medical system. To get that diagnosis, you've got to go to a family doctor. First of all, you got to have a family doctor, and we know in Ontario, not everyone does. So how do they access it? Sometimes there's a walk-in clinic, which is a different system from a family physician whom you're rostered with, which is different from a nurse practitioner. And then you've got to get blood work done, cognitive testing done, imaging done to get the diagnosis. And sometimes that means also being referred to a specialist. That's a different system. And then there's the whole acute care system, which is, we're talking about the hospital system. Let's say you get the diagnosis. No one usually only has dementia. They also have many other health conditions that need to get managed, right? You mentioned your dad who had a series of strokes. Those strokes probably got picked up in the acute care system when he might have had gone to the hospital, right? That system is not always talking with the family physician system, which is what's called primary care. So these are all the systems we're talking about.
Dr. Sivananthan, I'm exhausted.
You should be, right? That's how caregivers feel. Because these systems are not always interconnected. They're not integrated. And that is what we're talking about. When we mean this pathway, we've got to have a clear way in which a person knows where to get a diagnosis, what happens after that diagnosis, when do they need to go to the ER or to the hospital, where and how do they access a specialist, when do they go to the Alzheimer's societies or the Parkinson's or the Heart and Stroke societies, and those should be coming to them. It should not be them having to go out and figure all of that out. That's the system. And that's where I talked about cancer and stroke. They're not perfect systems, but they are much better at being integrated so that the onus is not on the patient or the families to figure all of that out.
If I am hearing you correctly, the goal of the Ontario Dementia Task Force is to systemically change how this disease is managed from every aspect of point of care that a person and their caregiver will experience.
You said it better than me. Yes, exactly.
How good are we doing right now with all of these things?
Well, I'll start with Ontario because we're talking about the Ontario Dementia Task Force. What we realized as we started talking to all of these different organizations is that there are many, many people doing excellent work. A lot of healthcare professionals and programs and people who are delivering really good care or trying their best to deliver high quality dementia care. And our government, the Ontario government, invests a lot of money into dementia care. There are dementia programs that are funded. There's programming in long-term care that's funded, home care that's funded. So it is not just a lack of funding, but it is that systemic approach to how we fund and how we care, which is that what we call discrete funding. So it's a pocket of money that goes to the Alzheimer's Society. Then there's a pocket of money that might go to the Ontario Caregivers Association, a pocket of money that's going to home care, some that's going to family care, some that's going to hospital care. But if you don't have someone who has their eyes on where all of this money is going, how is that being integrated? And how is the patient experiencing that care? Well, then you're going to have this disjointed approach, right? And just to give you an example, dementia, even from a health-only perspective, the Ministry of Health is responsible for dementia. The Ministry of Seniors has a responsibility for dementia. The Ministry of Long-Term Care has responsibility. Ministry of Housing has some of it. The Ministry of Economic and Social Development. You get my point, right? All of these different ministries alone are responsible, but where's the integration? That's what we're missing for dementia. And that's why caregivers and families are feeling it, because they have to function to do all of that. In addition to all of the caregiving and unpaid caregiving, might I add, that they are providing.
Why was it important to you when you were establishing this task force to make sure that you were including not just the people who are the paid caregivers, but also including those unpaid caregivers who are the boots on the ground, lived experience with a person living with dementia?
Oh, this work would be impossible. It would just not even be conceivable without people living with dementia and their caregivers, because they are the engines. They are the voices. They're telling us what their experience is so that we can make this systemic change, right? And I mean, I'll go back to, I used to work for the World Health Organization, the WHO, when they first recognized dementia as this global priority. And I will never forget, we had a global kickoff meeting. So we had like 200 country representatives come to Geneva, and we were starting to talk about the need to develop some kind of an action plan around dementia to support all of these different countries in addressing it, thinking about it as a priority, first of all, and then figuring out how to address it. And we had people living with dementia who were a part, front and center in that meeting. And there was an advocate in particular. Her name is Kate Swaffer. She's Australian. And she talked about her experience when she was first diagnosed. She said, basically, her physician diagnosed her and then spoke to her partner and basically said, yeah, so like immediately, as soon as that diagnosis happened, she was no longer a person who could function. And they said, yeah, you need to go home, get your affairs in order, write up your will and start planning for basically dying. This is a 10-year journey on average. And you're told at the beginning of that journey now that you need to plan for your death, and that was it. And she defined this as prescribed disengagement. Basically, that she was told, and a lot of people are told up front, that they're done and to disengage from their communities, disengage from their work, that their purpose is taken away from them. That has always stayed with me because it changed the tone of that whole conversation with all of these countries, right? All these country representatives, ministers of health who suddenly went, oh, wait, we're not just talking about a policy or a system. We're talking about people. right? That was grounded in that. And that has always been my experience in all of the work afterwards as well. When I was at the Alzheimer's Society of Canada and we were doing work in research, and often people think of research and researchers as people who, who are working in different theories and biological fields or clinical work. And how does a person living with dementia engage in that? But we used to have research conferences and meetings. And when we started having people living with dementia and care partners at the table, they started driving and changing the kinds of questions that researchers were asking. Because, researchers, by definition, you are a curious person and you're going to pursue that curiosity because there's an interest there. But then when you started hearing from people, you're connecting your research question to their need and experience. And the same goes if you've lived that as a caregiver or a care partner. Like, the reason you've started this podcast is driven by that. And it was the same for Alex and I. It was driven by our experiences as caregivers, as family members who were touched by dementia, and just how futile it could feel and seem. And we wanted to change that. And we feel there's a lot of hope, actually, from a lot of the work that we've done now and our learnings from other conditions, that it is absolutely possible to do for dementia as well.
When was it that the World Health Organization determined that dementia was a global crisis?
2016 or 2017, around there.
So incredibly recently.
10 years, yeah. Yeah, not that long ago.
How much dementia care is being provided by unpaid caregivers?
The numbers are astonishing. Actually, this was one of the questions that we had when I was at the Alzheimer's Society of Canada. We wanted to try and get some numbers around it, but the estimates are that on average, caregivers are spending about 26-ish hours a week of caregiving, and that's at the early stages of dementia. But as the dementia progresses and the person's needs increases, it can go up to 40 hours of caregiving a week. That's a full-time job in a week that a person is trying to provide while still working, parenting, fulfilling all of these other roles. So collectively, the number is roughly 470 million hours of unpaid caregiving annually. And if you were to try to convert that, that's the equivalent of about 235,000 full-time jobs. And that is about $7 billion annually at like just basic minimum wage, right? So the numbers are huge. I think the best way I would summarize this is that if unpaid caregivers stopped providing the care that they do, our health system would not absorb the cost. It's not possible to absorb that cost or to absorb the hours, which makes it even more important that caregiving supports and respite, day programming, training have to be put in place to be able to support caregivers so that they don't burn out. Because the number one predictor of whether a person who's living with dementia ends up in the ER or moves to long-term care is if they have a caregiver and if that caregiver is in crisis or distress or not. That's the predictor for when the person then has to access acute care or move to long-term care. That's the number one predictor. That is how essential unpaid caregivers are.
How much do you think ageism and a general sense of being disengaged with seniors in our population has to do with the overall attitudes towards dementia?
My personal opinion is that it is one of the biggest drivers. Ageism and stigma. It's a double whammy because we think about dementia mainly as a mental health condition, if not neurological. So there's that stigma, which has started to shift dramatically for mental health. And so hopefully is also having that knock-on effect for dementia. But ageism is a huge, huge driver. And look, we don't even need to talk about it because we saw it fulfilled during COVID. Canada has the highest, it is a statistic I'm ashamed of, that we should be ashamed of. Canada was the country with the highest number of deaths due to COVID in long-term care. Because what we did was we created these protective rings around young adults, around children, around emergency room hospital settings, and we did not provide that to long-term care. And so of all the global numbers, all the COVID deaths, Canada's is the highest when it comes to older adults who have died of COVID, and it was in long-term care. And of course, the highest proportion of people living with dementia are in long-term care.
We should be profoundly ashamed.
Huh.
Where do you see the possibilities for change and improvement?
The way I approach it is all of the things we have, our health systems, our social systems, we build them, right? And if we built them, that means we can change them. That is how I have always approached things. And even something as big as these systems were still created by us. And I tell this story sometimes because it again had such a profound impact on me. I was at a dinner and I was talking to a lady who was a nurse. And, she asked me what I do. And I say, I work with people living with dementia and really trying to shift the system of care so that we have better coordination of care for dementia the same way we do for cancer. And she stopped me mid-sentence and she said, "Oh, you can't say that." I said, "Well, hold on. What do you mean I can't say that?" Like, I thought she was going to say, something else about how cancer is not perfect and it isn't. There's all these gaps in the system, all of that. And she said, "No, you can't put cancer and dementia in the same sentence because they're not the same. Cancer is treatable, it's curable, and you can't do anything about dementia." And I thought, whoa, this is a healthcare professional, it's a nurse who's telling me this. And I was flabbergasted. It also pissed me off. So later, I went back and I went, I need to understand the cancer system, the cancer health movement. How did this get built? How did it get driven? And there's this fantastic book I recommend to anyone who's ever interested. It's called The Emperor of All Maladies. And it's a massive book, but it basically tells the story of cancer, tracing it back to its origins, like its histories, back during like the Egyptian times when Egyptians identified cancer, how they identified it, what it looked like, and the whole pathway for how we came to address cancer as a condition and invest in it. And when you look at that, you actually see so many parallels to where dementia is now. And you see the same thing for stroke, same thing for HIV, AIDS, these massive conditions that had profound impact on humans. What you see the parallels are, 50 years or more ago, the same stigmas around cancer existed. People didn't want to say the word. It was the C word. Physicians would not provide the diagnosis. They wouldn't tell people that they had cancer because they felt that there wasn't much they could do about it. It was a fatal condition. Families didn't want to acknowledge it, didn't want it talked about, or they would tell the families but not tell the patient. The treatment options were limited. There were those early forms of treatment at the time, but they didn't have great outcomes. And the side effects were very high, right? They were bad side effects. So people didn't want to try those treatments. The research was just beginning. And there's so much similarities to where we are with dementia. The same kind of idea. There's not much you can do about it. Do we need to even provide the diagnosis? Treatment options are very limited. But we know now, rehabilitation is something that we don't talk about enough for dementia. But the ability to be able to support people to maintain certain functions for as long as possible, or to find an alternate way, right? If you're a reader or you're a writer, or if you want to be able to maintain your balance and mobility, these are things that you can start putting in place now to try and support for longer so that the progression and the impact of that progression is more limited. So speech therapy, occupational therapy, physical therapy, cognitive therapy, those are things that we can and should be offering to people living with dementia, but we don't. It's not part of a system of treatment. Thinking about those lifestyle risk factors we talked about, those are still valuable even at the point of diagnosis or in those early windows and stages of dementia that we, again, don't offer. We don't talk about those the way we do for diabetes, for example. There's a whole lifestyle approach that we don't take. Those new treatments that are starting to come out, the lecanemabs, donanemabs, etc., those are a first class. They're not going to be perfect. They are going to have major side effects and treatment options. And I'm not promoting them, but what I am saying is that we need to understand they are the first out of the gate, and that we need to continue to invest in dementia so that we can see more and more of those treatment options come out. And that was the same for those early conditions of HIV, cancer, stroke, as it is for dementia. So this is where the ageism and the stigma has to be dispelled. We need people living with dementia talking about how important it is, pushing for these treatments and supports, or else we will not have a survivor of Alzheimer's or dementia, because we need to make those investments for that survival to happen. The same way we now have survivors of HIV/AIDS, we have survivors of cancer, because we needed to push for those things and we needed our systems to be able to support them.
You give me so much hope, and the correlations you draw there make so much sense to me. I think it is also indicative of the time that we're living in, where people seem to want these immediate results, that we should be able to fix it. Well, we fixed cancer, or we fixed HIV/AIDS, and to your point, that took decades of research and advocacy and false starts and challenging beginnings of protocol to get us to a place. I was out with a friend last night who lives with cancer, and she was like, I've got to make sure I eat because I have to take my chemo. And, out she comes with her sparkly little thing and she pops a pill. And this was unheard of 30 years ago. So we can get there. There's no reason why dementia cannot be researched and advocated for in the same way that those other diseases were. I've never heard it portrayed this way, Dr. Sivananthan. I'm so excited.
Me too. I believe it. I feel it. And I know that others can get there as well. And to your point, even around, as you said, your friend who, she has a path. She feels there's a path. And then, I received my letter telling me I have to go in and get a mammogram, right? We've now started that public movement towards screening, thinking about prevention and risk reduction. I know we can get to that place for dementia as well, where we can start addressing things that way.
So currently, right now, we are having this conversation in 2026. I'm time stamping it because when we have our next conversation, it's going to be different. What are we doing right?
So we are doing a lot of things right in that when we're thinking about systems, we recognize dementia is a disease. It's a condition of many different diseases. We now treat it that way. We understand that. We have started investing in many different programs that support people better. So thinking about day programs, respite programs, we do have these treatment options that are starting to come through the pipe that are driven pharmaceutically, but there are also non-pharmacological treatments that are starting to come through as well. So there are things we are doing right in first even recognizing it and the magnitude of it. We're all touched by it. But I do think that as more and more people are feeling confident enough to talk about their stories, share how they're feeling about it, ask and push for these things, the system and the politicians and the decision makers are responding. And that is also right. That is good. It means, there's not a denial. And I think that was where things were many years ago. And we are doing those things right as well.
How much in this task force is it also being like, we have to address the unique needs that caregiver is going to experience with the person who is the patient?
Yes. In fact, caregiving supports, education, and needs are one of the core pillars outside of the needs of people living with dementia. Because you're right, for the longest time, they were kind of lumped in with, it's dementia and what needs to be done. But now we are recognizing that caregivers themselves have their own needs that need to be addressed and facilitated. And in fact, I had a conversation recently with a wonderful clinician and researcher, Dr. Jasneet Parmer, who lives in Alberta. And she is a part of a movement that has started pushing to recognize dyads, so people living with dementia and care partners, as both essential. And in particular, she said this thing that really clicked for me. She said, for the longest time, we talked about caregivers' risk. So there's a caregiver's risk assessment that gets done, which is great. Okay, good. We recognize that risk and then maybe start putting some pieces in place for them. But now we need to start thinking about a caregiver's assessment upfront, right at that diagnosis point. We also assess the caregiver and start facilitating what they need separately and immediately. Instead of waiting until that caregiver is at that point of burnout, they are, mentally distressed, physically distressed, because we know as caregivers, a lot of caregivers will put off their own health needs in order to take care of their person. We also recognize that, not all of those relationships are healthy relationships, right? There's trauma, there's all sorts of things attached. And here we are expecting people to just step back in sometimes to keep providing that care. So now that we're recognizing that, we're seeing that both of those things need to be addressed and sometimes need to be addressed separately and not just as only the person living with dementia and what their needs are. Because going back to that backbone discussion, if unpaid caregivers stop providing care, we're done. We're hooped. We're up the creek. And one of the last statistics I think I wanted to share is we know that over 50% of caregivers, particularly caregivers of people living with dementia, report stress, mental health distress, complete burnout to the point of crisis. And when we start looking at our systems and those points of care, we're seeing that manifest. We're seeing people living with dementia who are coming to the emergency room not only because of their health emergency, but because their caregiver has hit a caregiving emergency. They can no longer manage that care anymore. And now they're staying in what are called ALC beds, alternate levels of care beds, which are managed in the hospital under an acute umbrella, which costs us so much more than they need to be. And this is, again, why it is so critical that we are addressing those caregiving needs early and right up front and throughout that journey, as opposed to waiting for the crisis points.
If people are caring for a person living with dementia right now, what is your number one recommendation for them at the start of this journey?
The number one recommendation, I'm putting this in place for myself as well, is recognizing you're going to be a caregiver no matter what, in some way, shape, or form. And starting to think through right away, not just the supports for your person, but what are the supports you need separately from what that person has, and starting to think through that right now. Ideally, you want to do that before you are fully a caregiver, right? But I have started thinking about that. Like, what's my village? How do I build that? Who are those people? Do I have enough money to do this financially? Because this is, it's a conversation we have a hard time having, but this costs money. This is going to cost out of pocket for caregivers to pay for the kinds of care they need until our systems are put in place. And sometimes even with those systems, you still don't have enough. But particularly for people living with dementia, because we don't have the pathways and systems in place, a lot of this is out-of-pocket care. And there were headlines just even recently. It's costing enormous amounts, $10,000 to $20,000 a month sometimes, to provide the kind of real good, high-quality care that you need. So start thinking about that now. Can I do that? What does that look like? What do I need for my own health conditions? Because if I don't take care of those, my person is not going to get the care they need either. Because when I burn out, that's it. It's done. I would also say for people to access the nonprofit care that is available. A lot of people don't realize that there are so many nonprofit organizations that offer really helpful supports and services, and it can be specific to the type of condition or disease that the person has. But there are broader wellness organizations and mental health organizations, et cetera, that also provide care. Access those. It is very hard because initially you're still grappling with, what does this thing mean? And I don't want to tell people about it or talk about it. Talk about it. Tell people. Because when you tell them, you are giving them permission to ask questions and to support you. And if they don't know, then we kind of tiptoe around it and we don't deal with it and deal with it well, right? So give people that permission and give yourself that permission to deal with it too.
People are going to want to know, can they get involved with the task force? Can they reach out to you? Can they follow along?
This is open. I mean, this is one of the privileges of being funded by the Weston Family Foundation, is that this is something that we can share. These are recommendations we can share, but also that people can engage in. And so when we first announced it, we had a lot of folks reaching out and saying, how can I share my story? How can I engage? Please reach out. The Brainwell Institute is also a nonprofit, which means that we are open to engaging and working with people. This is not a behind closed doors approach at all. And this is also something we want to co-design with government. We want to enable government to have this work move forward. There is a bill, Bill 121, which we call the Dementia Care Bill, that's making its way through. This work supports that bill, implementing that bill so that people can feel the real care at their point of care, at point of contact. So if you're a person living with dementia or a care partner who wants to engage, reach out to the Brainwell Institute. We have an info line, an info email and form that you can fill out. We are in the process of getting a landing page specific to the task force up and running so that people can engage, share their stories, see updates as it goes. This is very much a publicly shared task force. That's why it's been set up that way.
Does it matter what stage of the disease the person is at to be able to participate in this task force?
No, I think that part of the journey of dementia is that we are talking about people on this broad continuum, right, over this long journey.
Great.
And if people feel that whether they're even at the end stages and they can still communicate, whether that's being done with their caregiver or with their family facilitating, absolutely. This is not an only early stage game or conversation, because we do need to recognize and talk about how this journey goes. It's a difficult journey and it is a long journey. And we need to acknowledge all of those aspects of it, right? Including palliative care, end of life care. That's why we're having this whole conversation about MAID in this country right now. Medical assistance in dying. Part of it is also that if we don't have the systems in place, people feel like they don't want to be a burden. They don't have any other options. And so accessing MAID is part of that. And I think it needs to be part of that conversation, but we need to acknowledge that because we've not set the systems in place, that is also part of the reasons that might drive people there. But that means talking to people at that end stage as well. So if you're a family member, a person living with dementia in long-term care, and we've had people who've engaged in our research projects when I was at the Alzheimer's Society who are living in long-term care, living in assisted living, but were still able to engage and wanted to participate. And that's absolutely the case for this task force as well.
My favorite way to end each and every episode is with this question. How can we better support caregivers?
I think the only way to better support caregivers is to change the systems that they're having to deal with. And that is what we are working to do.
Well, I think I've been waiting 10 months to hear that answer. Let's change the systems, folks. Dr. Sivananthan, what you are doing is going to change things, and it must be so exciting for you. I hope you feel all of the support. We here at this podcast give you all of our support and are here to follow along and help in any way we can. Thank you so very much. And thank you for being here. I have no doubt we'll have you back on the podcast real soon. If not before, certainly for our Alzheimer's Awareness Month in January.
Thank you so much, Teri. I love being here. I loved the conversation, and I so appreciate you having this conversation. It's one we need to keep having, and we need to keep pushing and changing. So I'm grateful. Thank you.
What a wonderful and necessary new program. I really think that this is going to make a difference for caregivers. We will be following along with the progress of the Ontario Dementia Task Force. Thanks to our sponsor, RBC Wealth Management, and thank you for listening. We love to bring good news here on the Heart of It All. My co-producers are Jess and Carrie from 6 of 1 Digital, and I hope you have found us on socials at the Heart of It All Pod. That's HART. We love hearing from you there. New episodes of the pod every Tuesday. Until then, please take care.